recent years, there have been evidence that foramen ovale patient may be a pathogenetic factor conducting and contributing to the progression of arrhythmic syndrome in the population of detected in 1757 of cases and can cause paradoxical embolism. In this regard, it is relevant to think about the need for correction of this risk factor in the treatment program for patients with atrial fibrillation. Let me present to your attention a report with a clinical case of stage treatment of patient foramen ovale with persistent atrial fibrillation, heart failure with a moderately reduced left ventricular ejection. And adjective. Dear Evgeny Zhelyakov, the floor is yours.
Dear friends, dear colleagues, good day. Today I'm going to talk about endovascular occlusion of patent foramen ovale P4 as antiarrhythmic tool for treatment of atrial fibrillation, AF. Worldwide, AF is the most common sustained cardiac arrhythmia in adults. At this time, estimated prevalence of AF is between 2 and 4%. The pathogenesis of AF is complex, but often results from the interaction of triggers in the pulmonary veins, the vulnerable substrate in the posterior left atrium, and also provokes by autonomic nervous system dysfunction and underlying comorbidities. Before talking about the pathogenesis of P4 as a risk factor for AF, I would like to focus on the differences P4 from atrial septal defect and also prevalence of P4 in general population. The difference between ASD and P4 is that anatomically ASD is the true defect or a fenestration within the septum primum, while the P4 is just a failure of the septum primum to fuse with septum secundum after birth. P4 is common, present in about 1 in 4 people. The most of them will never find out it, as the most don't suffer any symptoms or health issues. P4 is a risk factor for several serious clinical syndromes, including paradoxical systemic embolism, ischemic stroke, and myocardial infarction, decompression diseases in diver, possible cause of migraine headache, platypnea orthodoxia syndrome, maybe AF. Particularly in 2000, data was showed that among patients who had cryptogenic stroke or TIA with P4, which was verified by TF, was significantly more often induced during the P study. Also, the parameters of refractoriness and conduction velocity in both atria were low, indicating a high vulnerability of the atria than in patients without P4. May the P4 influence to ablation results? The data is controversial. In 2008, Knecht and colleagues demonstrated in a group of 203 patients with paroxysmal atrial fibrillation that presence of P4 didn't affect the results of the pulmonary vein isolation, the maintaining a stable sinus ring for 50 months of follow-up. Recently, also data were published that P4 is one of the independent predictors of arrhythmia recurrence after cryoablation of persistent atrial fibrillation. The authors suggested that P4 may be a trigger for atrial ectopy that trigger AF, and the functioning of the right-left shunt in the atria leads to the entry of biologically active substances such as serotonin, etc., and platelet aggregates into the left atrium, which under normal condition undergo detoxification in the lung. Since it enters the left atrium, it can lead to the development of fibrosis, arteriopathy, and progression of atrial fibrillation. How P4 closely influence to atrial fibrillation time course. According to the Closure 1 study, which included 860 patients with PE4 occlusion, the incidence of AF within the first year after the procedure was 5.7. There were no episodes of AF observed in the group of patients who underwent antiarrhythmic treatment for arrhythmia prevention alone. The authors suggested that development of AF in the early period may be associated with inflammation due to the interventional. It is indirectly supported by the fact that by the end of the follow-up period, the AF incidence decreased to 3.9%. In 2019, Carpenter and co-workers published the results of long-term follow-up of 384 patients with atrial septal defect closure. Before baseline F was detected in 74 patients, 20%. Fifteen of them underwent ablation before septal occlusion. The follow-up results indicated that 80% of the ablation cohort were free from atrial fibrillation at the 1 year follow-up. No recurrence in 36% of patients after ASD closure without ablation, and in 80% patients without pre-existing atrial fibrillation, the new incidence of IF during the first year of follow-up was surprisingly low, only 0.3%. Recently, we published the case of treatment of patients with persistent tachysystolic atrial fibrillation, heart failure with a moderately reduced left ventricular ejection fraction and PE4. It was a 50-year-old man with body mass index about 28 with persistent atrial fibrillation. Duration was 3 months, who was admitted to our hospital due to worsening of heart failure symptoms, which corresponding to NIHA 3 functional class. The patient had been receiving optimal medical therapy in accordance with current recommendation: ACE blockers, diuretics, beta blockers, amiodarone, rivaroxaban. Echocardiography showed a moderate decrease in ejection fraction of left ventricle 41% and an increase in the left atrium and right atrium. In our clinic, we excluded coronary artery diseases, myocarditis, thyroid dysfunction as a reason of arrhythmia. The patients underwent a radiofrequency ablation in the left atrium with successful restoration of sinus rhythm by external DC cardioversion. During procedure, left atrium was catheterized via PE4, and PE4 was verified. 4 months later, despite a stable sinus rhythm, the patients maintained a moderately reduced left ventricular ejection fraction, only 44%, and also dilatation of the left atrium and right atrium. Transesophageal echocardiography revealed an aneurysmatically altered atrial septum and positive bubble test with large number of bubbles, and also long tunnel with diameter of 4 millimeters. In accordance with current recommendations, the patient also underwent endovascular occlusion of PE4. Nine months later, after PE4 closure, patient had sustained sinus rhythm and dramatically improving of symptoms of heart failure, which consisted with NIHA 1 functional class he discontinued diuretics, amiodarone, and rivaroxaban. And you can see in this slide, in 1 year after onset of treatment, we revealed decreasing of heart chambers diameters. Ejection fraction was 56%, left atrial was 41%, and right atria 43 to 68 millimeters. And we concluded that such a combination therapy in patients with persistent IF, heart failure, and PF4 with right to left shunt, which including optimal therapy for heart failure, antiarrhythmic drugs, and ablation of atrial fibrillation, and also interventional closure of PF4 allowed us effective control of sinus rhythm and reduction of heart failure symptoms with reverse remodeling of the heart. After that, we conducted a case control study, which included 42 patients, 18 women who underwent ablation for AF. The case group comprised 7 patients with atrial fibrillation and PF4, 3 women, mean age was 48 years old. In this group, we performed ablation and subsequent interventional closure of the PF4. The case group was well matched with in 1:2 ratio to patients with PF4 who underwent ablation of atrial fibrillation only without subsequent PF4 closure, and matched in 1:3 ratio to patients with AF without PF4 who underwent ablation in the left atrium after transeptal puncture. Patients in the ablation-only in puncture group were retrospectively selected and matched with the case group for age, gender, and AF pattern during the same period. Before treatment, there were no significant differences between groups after matching in age, AF type, comorbidities, and also antiarrhythmic drug character and anticoagulation therapy. On the left and right atrium size, ejection fraction parameters. Between 3 and 12 months after ablation, patients in the case group underwent TE to reduce the risk of embolic complication, and in 2 patients shunting from the left atrium to right was revealed. A positive bubble test was detected in 6 patients. In 2 patients, the length of PF4 tunnel exceeded 4 millimeters. Patients in all groups were followed at 12 and 24 months after the procedures with ECG registration, 24 hours Holter monitoring, and echocardiography. As a 2 years of follow-up after PF4 closure, antiarrhythmic therapy persisted only 1 patient due to recurrence of AF in the PF4 closure group, blue line, versus 8 patients with PF4 and with PF4 without PF4 closure who underwent only catheter ablation. And the same results were revealed in patients without PF4, which underwent ablation with transeptal puncture, black line. According to echocardiographic parameters before and after treatment, 1 year after closure, there were no statistically significant differences of parameters before and after PF4 closure. However, there was a trend towards a decrease in size of the chambers of the heart compared with no PF4 closure group and no PF4 at all group. Our concern about this tool for treatment of atrial fibrillation is repeat ablation is more challenging, and it may be downside of this approach, but is not impossible because left atrium catheterization for left atrium catheterization we can use robotic systems or a transeptal puncture with eyes. In conclusion, P4 may be a potential risk factor for development and maintenance of atrial fibrillation. Interventional P4 closure may be an effective and necessary tool in the AF treatment strategy. Randomized clinical trials to evaluate the role of P4 closure in patients with AF are needed. Thank you for your attention.